right, ladies, I want to welcome Dr. Lunt. I'm super excited about our conversation that we're going to have today, and I just want to introduce him to you. I know several of you know him, but Dr. Lunt received his medical doctorate at the University of Arizona and completed his residency at Wilford Hall Medical Center in San Antonio, Texas. Dr. Lunt practiced OBGYN in the United States Air Force, fulfilling an 8-year commitment. He was chief of obstetrics. I probably said that wrong.
Obstetrics, close.
Obstetrics. Okay, say it again.
Obstetrics.
Obstetrics. Okay, and gynecology. I like pushed dictionary several times trying to get that word down. At Ellsworth Air Force Base in Rapid City, South Dakota, and he was the chief of ambulatory, did I say that right?
Ambulatory, right.
Okay, services at WHMC in San Antonio. Dr. Lunt opened his practice in St. George, Utah in 1998. He is board certified by the American Board of, I'm going to let you say it.
Obstetrics and gynecology.
Perfect. He's married to Diana Lunt, and they have 6 children.
Correct.
So thank you, Dr. Lunt, for being willing to meet with us. I know we've kind of had a little hit and miss a little bit. Dr. Lunt just got through delivering, so we kind of had a little delay, but I think all of us women will completely understand that. And before I get going, I just wanted to let you know, you probably already know this, you're married to a woman, and I'm sure you have daughters. Women talk.
Yep.
We talk. And one of my members was telling me how much she loves and adores you. You delivered her daughter-in-law's twins who were high risk twins. And the mom suffered with some anxiety, a little bit of almost a trauma because of how much she had to be bedridden and the things that were going on. And she said you went even out of your way when the babies were in the NICU and went and visited the mom, and she just couldn't say enough good about you. So I just want to let you know that those things get talked about, and we appreciate that so much, that obviously you love your job and you love the women that you work with, and you really take it to heart. So
thank you.
Thank you. So, all right. So what we're going to do is we're first going to talk a little bit about those newly married and the kind of young married moms a little bit. We'll hit those just a little bit there first. So I've had a lot of questions on birth control. So you have the pill, and you have an IUD, and then you have, and I don't know what they call it, but the injection they can put in your arm.
Well, there's an injection called Depo-Provera, and there's also an implant called Nexplanon.
Okay. All right. Awesome. So can you tell us, let's talk about those first. What are those injections, and who would be ideal for using them, and the pros and cons of those?
Well, so the way I talk to people about contraception typically is we'll say there's barrier methods, of course, like condoms. Then there's hormonal methods, and the hormonal methods have a lot of different ways now. They have pills, shots, vaginal rings, the ring that you can put inside the vagina. They have the subdermal implant called Nexplanon, and then they have the Depo-Provera injection. The advantage of some of those, of course, is you don't have to remember to take a pill every single day, which is where most of the time it fails. If there's a failure, it's usually due to human mistakes rather than it is, a failure of the actual contraception. But anyway, the Nexplanon is an implant that we put underneath the skin of the upper arm. We do it in the clinic. It can stay in for 3 years. The ideal person for that is someone obviously who would like to delay pregnancy for at least a couple of years. And it's nice because, again, you don't have to worry about taking a pill or doing whatever. The drawback of that is that sometimes there can be some irregular spotting for quite a few months after that's in. Most women will get to the point where they don't bleed at all with that.
Oh, okay. So there is hormones of some sort in that.
It's a progesterone-containing rod. It does suppress ovulation, so it is hormonal. So it is hormonal. The Depo-Provera, again, is an injection, an intramuscular injection, that lasts for 12 weeks. It has to be repeated every 12 weeks. Again, the advantage is just not having to remember to take something each day, but the disadvantage of that is that some women will respond so profoundly to it that if they decide, okay, I'd like to try to get pregnant, it can take some women up to 18 months before they'll start to ovulate again. Most will ovulate within 3 to 6 months.
Oh.
So anyway, the ideal people for these, of course, there's obviously someone who's trying to prevent pregnancy. Most of the time, it's for someone who wants to prevent pregnancy for some extended period of time. But yes, they are hormonal, and all those things that we've talked about so far do suppress ovulation. IUDs, intrauterine devices, they have different ones out now, ranging from 4 to 5 to 10 years, depending on the one that's picked. IUDs do not inhibit ovulation, so the woman will continue ovulating throughout the cycle. They just prevent pregnancy, and so that's an advantage for some, that they like the fact that they are going to have, whatever hormone they see or feel is the hormone they are making. So again, they're nice too, especially for people who want to delay childbearing for some extended period of time. Now I should go back and say there are some other advantages to hormonal contraception, those that suppress ovulation. Some women who have painful periods or heavy periods, those types of birth controls can also help with those, with the heavy bleeding and the painful periods. So.
Okay. With the IUD, I've heard there's like a couple different ones. So is there one with hormones and one without hormones?
Correct. So there's two broad categories. There's a progesterone-containing IUD, and then another one that's non-progesterone. The Paragard is the most common non-progesterone one. It's copper. It can last for up to 10 years. Its contraceptive benefit can be for up to 10 years. Its one drawback is that some women will have heavier periods with it. The progesterone-containing IUDs, they thin the endometrium, and so most women who use a progesterone-containing IUD will also have the advantage of either lighter periods or no period at all. And so many women will choose those just based upon the menstrual benefit.
Okay. So I had one member that asked me, she's had hers, let's see where I wrote this question down because I was going to do it. So she's had hers for 9 years. She doesn't need it for birth control.
Right.
But she doesn't want to have her period. Is it bad to let it go past the 10 years? Because I guess it's a 10-year one, apparently she must fill. Is it bad to let it go past the 10 years? Or she's like, I'm afraid they won't be able to find it.
No, they are inert. I mean, they're otherwise inert, so they're not dangerous. I would have a question about it. If she's not bleeding much or is keeping it in because she's not having a period, it probably is one of the 5-year IUDs.
Oh.
Now, obviously, if she were still using it for contraception, I would say you need to get it changed quickly because you don't want to trust it for birth control at this point. But if they're not using it for birth control and they're just using it for cycle control, I don't have any problem with people leaving that in until they don't work for cycle control anymore, and they can switch it out or do something else. But yeah, so I wouldn't use them beyond their period of time for contraception, obviously. Okay. But if there's cycle control and they're still getting good benefit from it, leave it in until it needs to come out. Okay. Until it quits working, I guess.
Yeah. Okay. Well, and I had heard, I mean, I never got to use an IUD, never had that opportunity. I had heard though, and maybe they're different now, back when I was childbearing, that if you got pregnant with an IUD in, it would naturally make you have a miscarriage. Is that true?
Yeah, you don't want to get pregnant with an IUD. The failure rate of IUDs is very, very low. So the risk of getting pregnant is very, very low. And still, we think that the most common reason for a pregnancy when an IUD is in place is that it's probably not in the right spot for whatever reason, expelled a little bit or whatever. But yeah, if you get pregnant with an IUD in place, obviously let your doctor know, because that's a potential issue. the very first thing they do is get you in and take a look and see if they can find the strings and then remove it. They would remove the IUD. That does many times cause a miscarriage. However, leaving an IUD in with a pregnancy is dangerous. It leads to lots of complications, and no one would ever recommend that.
Okay. Okay. That is good to know. Now, on the pill, obviously oral pills for birth control, I know there's so many. I was a basket case on the pills. I tried like 3 or 4 different ones. That's the reason I have 5 kids, 8 years and younger. It just didn't work with my hormones. I did not do well with the hormone change. Have they come up with better pills that are working with women that have sensitivity to hormone change, or is it just kind of the risk?
Well, all the pills that are commercially available now are all considered low dose, and so they have evolved over the years, and have all come down. They're much lower dose concentration for both the estrogen and the progesterone. Most pills are combination pills. They have both an estrogen and a progestin in them. Many of the side effects are to the estrogen component. Most people, if they're able to tolerate it for 2 to 3 months, will get over the side effects, and the benefits continue to increase, and the side effects continue to decrease with time. They're not for everybody. Some people do react more than others, and certainly it's not worth it. If you're miserable, it's not worth it. But they have evolved over time. Now they have them to where, there's only like 2 days out of the whole pack that don't have medicine in them. That keeps periods lighter. Many women now with the newer combination pills will not menstruate at all again, which is a nice thing. But not everybody tolerates them.
Yeah. Okay. All right. That's good.
But again, like I said, there's 2 different, they have the combination pills that have both an estrogen and progesterone in them. They also have a progesterone only pill, which many women tolerate a lot better, except that irregular bleeding is more common with those. That is the common pill that we use when a woman delivers and is breastfeeding, is that progesterone only pill or mini pill.
Okay. I had one member ask me, what is the most effective birth control, but on top of that, she also wanted to know, and what is the best, most natural birth control besides abstinence? And is there a natural birth control?
Well, many people will do natural family planning, where they will just use their cycle. Obviously, a woman who's menstruating regularly and ovulating regularly is only able to get pregnant about 24 to 48 hours out of each month.
Oh, okay.
Now, the problem is if a woman doesn't menstruate regularly, then it's very, very hard to map that out. They have lots of things to help, though. There's ovulation predictor kits, and many women use those to help get pregnant, but also many women will use that to know how to not get pregnant. So if they're ovulating, they know that's a time when they should not have vaginal intercourse. But they even have kits now that you can buy that you can use them every day, and it'll give you a plus sign or a negative sign as to it's safe to have sex, or today is not the day.
Yeah.
And so now many women do use, if they have regular cycles, they can use that. Almost universally across the world, somewhere between 14 and 16 days prior to the onset of menstruation is when ovulation occurs. The variable part of a cycle is the time before ovulation. But in a woman who's got that normal, 27, 28, 29 day cycle, you subtract 14 days and that puts you on about day 14, and you subtract 16 days and puts you on about day 12. And so many women will just say, well, what we're going to do then is, between days 11 and 16 or 17 of my cycle, we're not going to have intercourse, or we're going to use condoms, or we're going to do something like that during that time. And so you can do that if you've got regular cycles, but we don't encourage it if you don't, because then it's impossible to predict.
Yeah. Yeah. Well, they've come a long way with these home kits and everything. I mean, I never even have used anything like that. So that's pretty amazing.
Yeah. Some are relatively expensive, but they're all cheaper than a baby.
Yes, that's true. Okay. So when a a new patient comes into you who's just going to be getting married. She's not been sexually active. Do you have kind of a protocol that you go through in kind of making sure she's up to par, or is there literature you suggest for them? In my course, we talk a lot about sexual intimacy and how we often go into it so unprepared, especially Christian women who it's not something that's talked about, and it's also told it's wrong, it's wrong, it's wrong, it's wrong. And then all of a sudden it's good. And now you've got all this mental aspect that you're trying to deal with. So I'm trying to break that paradigm. We talk about sex a lot and how it's such a important part of a healthy marriage.
Right.
So these young girls that are coming in and, I'm getting married or whatever, is there a protocol you kind of go through with them in helping them understand the makeup of their body and how it works? Or
Yeah, well, anytime a woman comes in for a premarital exam, first off, we want to do an exam to make sure that physically everything is normal. And so they don't necessarily need to have a pap smear. In fact, we don't do that much anymore. But we do look to make sure everything is normal. So they make sure that the hymenal ring is open, that they don't have an imperforate hymen, something that would be difficult. So we ask them questions, to kind of get an idea about that. Are you able to use a tampon? Those types of things to kind of get an idea. But we'll do an exam to kind of make sure everything appears normal. And yeah, we always do talk about intimacy. It is a lot more commonly discussed now. I think moms are doing a better job now. We're not quite as nervous to talk about it as much anymore. So certainly many women are coming in a lot more prepared than even a generation ago. But we certainly try to go over what's normal physiology, what's normal sexual response. Certainly some things to expect in a woman who's never been sexually active before, so they're not startled. Because certainly there's some things that'll happen that they may not be prepared for, and we will go over all that with them. We also talk a little bit about the physics of vaginal intercourse. Many women don't even understand the axis of the vagina as compared to what their body is, and so we want to make sure that their partner is going in at the right angle and all these different things. So we'll try to go over most of those things, try to talk about it in as much in such a way to try to make it not so mysterious. If we talk about it as a matter of fact, then many people will be able to be much more open and talk about it at that time. And again, depending on how much the woman wants to do, we'll even sometimes get a handheld mirror so they can kind of look while we're examining, and we'll kind of show them some of the normal anatomy, things like that, to kind of help them, break down some of the mystery.
I like that. I really like that. I know when my daughter got married, she was away from home and she had to go get on birth control. So I wasn't even able to go to her first appointment. Yeah. So I had her call me in and put it on speaker so I could listen. I'm like, I want to be involved in this. I feel so bad I'm not there.
I think it really helps when moms come in for that visit.
Yeah, I felt so bad that I wasn't there. Luckily, her roommate, who's like her best friend, was able to go with her, and then I was on the phone. And the doctor did an incredible job, kind of like what you said. He really went through detail with her, and she was one of those that did not know a lot. And so she was very appreciative of that. So as a mom, I was super grateful to send her to somebody that was able to give her the lowdown of it all. So
and we'll talk about other things. We'll talk about the urinary tract infections that many of these women will get when they initiate sexual activity, and talk about some things to help prevent that. And so we do try to go over a lot of those things. And there's lots of good sites too. You got to be careful, of course, when you start looking for sites that are talking about these topics. But one good site that people can go to is acog.org, and that's our governing board. But on that site, they also have a patient education thing, link or whatever you call it, and so that gives you good peer-reviewed scientific information.
Oh, that is great. That is great. That would be great for these women to go to. Okay, now let's move a little bit into the childbirthing years. How do you feel, and obviously you've probably had many women that have come in and tested you out, want to see if they want you as their OBGYN.
Uh,
What's your suggestion to women? Obviously, a lot of my members aren't even here locally, of finding an OBGYN. What's your suggestion to them?
well, yeah, the first thing they want to do obviously is make sure that the person they're selecting is a board certified OBGYN. They want to make sure that the person has met those minimum requirements for training and education and all those things. So you want to make sure. But then the best thing is, especially if you have friends, you talk to your friends, you see, personality wise, how they are. Not everybody's for everybody, obviously, and some people work better for others. But if you have a friend who you trust and has seen someone, certainly that's a good thing to do. Just kind of ask. Back in the good old days, you could call labor and delivery and speak to some of the nurses, and they would give recommendations. But in these days, they legally can't.
Yeah,
So sometimes you might get lucky and call someone, and they might give recommendations. But most of the time, it's going to be just asking friends. And of course, today's world, heck, you get on and there's profiles on everybody, and comments and things like that. So those are the places where you can go to. Being careful, of course, because many of the people who've had great experiences don't comment. Sometimes
yeah.
it's only the angry people who comment.
That's true. That's true. I'm always weary of when I get on. I'm like, well, these are all negative, but that's probably the only ones that are complaining right
Yeah,
now and
yeah,
not getting on.
yeah,
So are
right.
you okay with a patient coming in and kind of interviewing, yeah, like asking you lots of questions? I mean, do you recommend that? Do you?
Yeah, I have no problem with that. We get that all the time. Women will come in and they may have already seen someone or they got appointments with other people. But yeah, we have that all the time where they just come in and they're talking to us, they're getting a feel for the office and things like that. Yeah, so there's no problem with that at all.
Okay, awesome. That's good to know. So, okay, so the next question is, if you're trying to get pregnant, how long do you wait before reaching out to your doctor for assistance for like
Mhm.
medication for ovulation and stuff?
Yeah. So a lot of that will depend, obviously. If the woman is completely normal in that she's menstruating every 27, 28 days, it's like clockwork. She doesn't have severe pain. All those things. Those are all things to let you know that most likely everything is okay. And what most people are recommended there, we use the definition of 12 months. It can take a completely normal fertile couple who's trying to conceive for the first time, because again, if someone's been pregnant before, it tends to be a little bit easier to conceive. But for the first time, we know it can take a completely normal fertile couple 7 to 8 months,
Mhm.
and then of course then you start mixing in all the other variables that can come in with that, and that's why we use a year. Now that does not mean anyone has to sit there and worry about it for a year. They're certainly welcome to come in and talk about concerns, and maybe there's just a few little simple things that they haven't thought about that can be discussed. Now, if a woman is only menstruating once or twice a year and is having other issues, severe pain, those types of things, that's not the same. And obviously, those people should be seen sooner because there's other things that may need to be done. But the definition of infertility is a year of actively trying to conceive and not being able to. But that is only for the person who's rock solid normal. Everything is good. Normal menstruation, not severe pain. Almost every woman has some discomfort with the period, but certainly if it gets to the point where it's interfering with activities of daily life or school or work, that may be something. So those would be issues to pursue much sooner than a year. But
Okay. And what about a somebody who's already had a child or two and they're trying to get pregnant a third time or whatever, and it's taking longer than it normally has in the past? Do they wait a year? Do you still?
no, and
No.
I'll typically tell those women, if they're actively trying to get pregnant, and again everything's good, we always ask these questions, are you guys able to have intercourse on a regular basis? In other words, if you've got a job or your partner has a job or you're away from each other for large periods of time during a month, that can certainly have a negative impact. But if everything else is good and they're able to have regular intercourse and there's no other problems, I usually tell people to stay 6 or 7 months, and if it hasn't happened, come in. We can at least talk and review and make sure everything's okay. So yeah, there are differences in women who have conceived before. And certainly, I guess I should say, if a woman has required something before, if she's required Clomid or something else to get going before, she shouldn't wait. She should just come in to get the ball rolling again.
Okay, that's really good information. I had one of my members that said, asked if her stomach muscles will ever come back after a C-section, and is surgery the only way for that to happen? She's like, will I ever be able to do a sit-up again?
Well, yes. That's with a cesarean section, with a normal cesarean section, muscles are not cut. So we do not cut muscle. They are separated, and pregnancy itself, of course, can separate those rectus muscles and certainly can make them not work as good. But there is no reason, after that 6 weeks of recovery after C-section, that a woman cannot get back into any type of normal exercise that she was doing beforehand. Now, we all know that things are never as they were before pregnancy.
Yes.
So some women will get, very dramatic separation of the muscles. They'll get that what's called diastasis recti, where the rectus muscles are separated widely, and they can even see a little bulge coming through there. And that hardly ever goes completely away. And short of a plastic surgeon going in there and pulling those things together, that's probably it. But I would certainly not do any of that till you're sure you're through having children.
Oh, okay. That's good to know. So if the stomach muscles weren't cut, but separated enough, then you may need surgery.
Yeah, but that's rare. I mean, that's rare. Very rare. Most women are able to, they may not feel great doing a sit-up or whatever, but it should be possible. And if there's significant things that are keeping them from doing it, that's reason enough to be seen.
Okay, so if it hurts a little bit to do this, I mean, say this person, I know this particular client, their baby's probably, I don't even know, 10 maybe.
Oh, yeah.
So it's been a long time. So she's not going to injure anything by trying to push herself through sit-ups or anything like that.
No, if there's anything that's not right, it's not right. And so there's nothing that's going to be hurt worse or anything like that. If it doesn't work, it's not because she was trying to do sit-ups.
Okay. All right. That is good to know. She's going to be so happy to hear this.
Yeah.
What are the pros and cons of choosing an epidural with labor? I'm a 5 epidural woman, actually 6 because we had to do one twice. So.
Well, I think the pros and the cons